Okay, hello everybody. I'm here at AAMI Exchange 2026. We're at day one, and I've got some guests who just wrapped up a session that I think was fairly popular and touching on a subject that has caught a lot of people's attention, which is how AI is changing the healthcare environment. Now, you're going to say, I've heard that before. Why do I need to hear it now? But we're talking about a perspective that I think a lot of people aren't really thinking about, which is going to be more along the lines of how people are interpreting data and responding to that data coming directly from patients in a more immediate manner, right? We're talking about alarm fatigue. We're talking about how nurses are looking at things. So with me today, I'm going to pull up my notes here just so I can cheat a little bit. I've got Jeannine Blake from the University of Massachusetts Amherst. Thomas McCoy, you're from Mass General Brigham. And Erin Sparnon, who a lot of folks know, System Evolution Incorporated now these days, right?
That's right.
All right. So the three of you are coming at this with slightly different perspectives, but let's start at a really high level. Why are we concerned about the data being generated by the AI movement more than, say, just big data problems in general?
Sure. So the way our backgrounds work, I've got 20 years of accident investigation and what can go wrong. Jeannine's got a background in clinical context, what is going, and Tom has the background in where the data is. And so in conversation, we really found out that machines that were built to notify somebody in the room about something happening with a patient, they were all built with the understanding that a caregiver would be looking at the patient first, then maybe looking at some data to correlate it with what they're saying.
Add context,
Right.
yeah.
Now we have patient data collected, aggregated with maybe EHR data, all data, flowing off, to EHR backends, to AI data lakes, to algorithms, to other things, to maybe alert people who are not in the room, who might be alerting the people in the room about conditions that may or may not be of any use depending on the clinical context. And Jeannine's got some really good stories about what that can look like.
Yeah, I think, so my background is surgical intensive care nursing. I was, bedside for a number of years at a level 1 trauma center in New England. And, as my career has progressed and I've entered, a real research field and spent some time with biomedical engineers and learned a lot more about how and where data comes from devices, with the lens of how we as clinicians may or may not use data specifically to make our decisions, right? That there is a value of data, but there's also nursing intuition, right? There's also this sense that you have that my patient's mental status has changed, even if it's just slight, right? There's something different.
Right.
I've had instances where I call a physician into the room, said, I know nothing looks wrong, but something's wrong. Right? I shared this morning. One of the scariest and kind of most impactful codes that I was ever in as a bedside nurse, it might have actually been my last before I left bedside, was the one that I didn't predict. Right? It was the one where everything looked right. The patient was waiting to go to a step down. She was up talking, had family there, and then she coded and it was out of the blue. And that shook me, right? Because at some point I became the ICU nurse who could tell when somebody was going to go downhill before they went downhill. And how that ties into our talk is that that's not based off of data, right? So when we're relying on data to interpret a patient condition, where is it that the context that a clinician uses to understand the patient condition, when does that get lost? And as we move towards, and I think perfectly appropriately so, we move towards other models of data interpretation, what gaps do we need to look for actively to understand that they're there so that we don't end up suffering as clinicians, as patients, et cetera, because we're not looking for those gaps and understanding where that intuition comes in when it's lost.
Now, before we dive over to your perspective, Tom, but feel free to jump in with what you know best. When I think about AI solutions, a lot of the time people are talking about, oh, we can get rid of the middleman or add a new middleman that can process this data, use it faster, because that's one of the things that really bogs nurses down in hospitals. Is as that they're a complaint I hear quite a lot is I engage more with devices than I do patients these days. And then we lose that human element you're talking about. So one of the proposals we hear a lot from innovators is, oh, but if we put an agentic solution into the middle of that, we're going to save nurse time and they can spend more time with the patients. It sounds like that's not the solution that some people think it is, or what's going on here? Where there can be the problems?
I mean, I think it's multifold, right? It's multifactorial. One is we're in a healthcare setting systemically where we don't have enough nurses, right? We're losing more nurses than we produce. And so there is a real need to take up some of the slack of the resource that we just don't have, right? So there's some fear about taking place of the human, right? But there's also some need to decrease the workload. But at the same time, we really need to recognize what is being lost if we replace a human element with a technological element. And as I was thinking about it as we were developing the presentation and talking about it today, a lot of the examples that I gave during our presentation of how an intervention may result from, let's say, bad interpretation of good data, or data that is not giving the full picture of the patient, or not in the context of the patient history. A lot of those things may not be conditions that people have even thought about, right? That has been really considered actively, because for nurses, it's just what we do, right? As a nurse talking to another nurse, I understand how you do it. I understand how you read the patient situation because I did it. But we don't often then voice it. And that's where I think a need happens. There's a need to voice that, to recognize what is being done at the bedside and how that changes when we adjust to adding some technological middleman, so to say.
Jeannine, when I hear people talk about administrative burden reduction, the technology they often point at is ambient clinical documentation, which has certainly come to physician practice. I don't know if I've seen it in nursing practice as much. And I don't necessarily think about it as having a big medical equipment role. Do you see ambient clinical documentation as impacting nursing, and do you see medical equipment having a special place in that technology's deployment?
So this ties to nursing time, right, and how much time is actually spent with the patient. There's been a couple of studies that talk about how much time is spent charting and documenting, and the number that I can recall is about 35% of nursing time is spent documenting, right? So in a 12-hour shift, that's 4 of my hours, right? There's another study that estimates approximately the same amount of time managing alarms, right? And there might be some overlap where we're documenting about alarms. I'm not exactly sure where that comes from, but in terms of reducing documentation through technology that, auto-verifies or moves towards the nurse not actually having to do the documentation, again, I think it's something that we have to weigh. There's a reward of not having to spend as much time in front of the computer because it's being done in a different way. And then there's the risk that we also have to apply of how often might this be inappropriate. And then it might be different in different contexts, in different units, where it's appropriate in some cases and not in others.
And that's making a lot of assumptions about the relevance of the data and the timeliness. And Tom, I loved your information about manually entered versus auto-entered data.
Yeah, so I think in our presentation here at AAMI this year, we did a little bit of a review of the Mass General Brigham experience with the implementation of biomedical device integration in med-surg floors. It's a technology we've seen for years in the operating room, in the ICUs. When we turned it on in our med search force, one of the things we found is that the data that flows through that integration pipeline, once it arrives at the EHR, it ends up looking a little different than the data that flows through the traditional nursing fingertip pipeline or perhaps the ambient clinical documentation pipeline. And so when we think about eventually deploying any form of artificial intelligence or non-deterministic computation at the bedside, recognizing that some of that provenance, how does the data come to be at the inference layer, is going to end up determining what that data looks like, and it'll carry a lot of knowledge. The nurse walks into the room, sees that the blood pressure cuff is actually under the wheel of the bed, and is less concerned about the alarmingly hypertensive reading on the monitor. The AI won't necessarily have the benefit of seeing that the cuff is in fact parked under the ICU bed. And so that decontextualization of the data is really easy to point to examples where the human in the room has just an unbelievable advantage in interpreting the data and dismissing it as non-informative.
Well, one of the things that we've heard a lot from our own AI standards committee, it gets brought up fairly often, is that when they want to approach data and they want to approach risk assessment and things of that nature, when you're implementing AI into a healthcare environment, it's always seen as something to be complementary to that human element, right? So it sounds to me like what you're describing just comes down to an education problem. We're using this new data, it's robust data. Now, do we just need to retrain nurses and doctors, or is there more to it?
There might be more to it based on what you found on the role of the caregiver and how often they used BMDI.
That's true. We did find significant role level variation in physician and nurse adoption was more immediate after technical go live versus some of our other allied health professions were slower to adopt at a role-based level, but they trend back towards that physician and nurse baseline as a long-term level. If you think about the model consuming that data, though, in that sort of first 180 days after deployment, who was collecting the data, how the data traveled, would have also informed the data the model was ultimately getting exposed to. And so when I think about it, retraining everybody, sure, we'll retrain a million times. If we're not retraining, it means progress has stopped, and that would be a tragedy. What are we hoping for? Minimally, I think we all have been part of investigating an accident at the bedside that we really wish didn't happen. We're all trained in the Swiss cheese model, and whether you're worried that the AI is going to take your job, whether you can point to examples that it's trivial to fool, whether you think it's going to be a miracle, regardless of your perspective, finding that next layer of Swiss cheese we can put on the chronic problem of medical errors, I think is really appealing. And this is sure to be one of them, but it's, in my mind, pretty unlikely to be miraculous. It's going to be another layer in our Swiss cheese stack, and that's great news.
Well, and I'd like to respond to that as well from an education standpoint and human factors lens, right? To tie it into the data that Tom brought is, yes, there was a difference in how patient care technicians interacted with BMDI and licensed clinicians. I pose the question of, is that an education piece or is it a workflow piece, right? There is a different job for patient care technicians than RNs and physicians who are taking the same vital sign and choosing to use BMDI or not. And I don't think it's related to the education, right? I think it's related to how they go about the tasks that they have to do and what tasks are on one person's plate than another, right? And if we look at it from a human factors lens and the training aspect and education it is very important that we do not lean on education and training as the way that we keep somebody safe, right? That it needs to work intuitively for anybody who steps up to.
You have an article on that, don't you?
I may have an article on it. And it might even be the same person with the same training at 3 o'clock in the morning versus fresh on their shift at 7 p.m. the next day, right? That how they interact with a device, how they interact with data, how they interact with another human interpreting their data, right? changes based off of the context of that clinician in the context of that patient.
Yeah.
And so it kind of, it's like everybody's favorite, not favorite answer of, well, how do we handle this? Well, it depends,
Yeah.
right? And it's that it depends that we have to consider when we're starting to move into a more technologically supported data interpretation, or where technology is coming in, and we have to recognize that humans, whether they're clinicians or patients or family members, right, AI inherently reduces them to data points. But what is it that is not shown there? It's the lived experience.
Yeah.
It's the current context of that patient or that person that gets lost, and we need to be very aware of that.
That's an important point. Erin, I wanted to wrap this up with a question that I think is pertinent after people are hearing through this. These discussions that we're going through, these points, all scream to me that it sounds exactly the same as what we've been talking about since 10 years on for alarm fatigue, right? And this is very much sounds like an alarm fatigue problem to a certain point. For solutions, to explore solutions, do we need to reinvent the wheel, or is it there are lessons to be learned from the past?
There are so many lessons to be learned from the past. We can learn from EHR deployments, where we learned that practice or policies are not transferable, but practices are. Like the practice of making a sepsis algorithm, probably transferable. Your actual sepsis algorithm, not transferable. We can learn from, alarm fatigue in that the volume of information can be, directly uncorrelated with the actual utility of the information, right? We can, the old adage of a broken clock being wrong or right twice a day, even if a system isn't perfect, it may still be useful. And so Tom had some good examples of how even imperfect data and algorithms can still be useful in the context for which they are built. And again, we can always learn too from, we all start with form a multidisciplinary committee. It's our favorite, right? But our talk was to help the HTM in the room as the people who can understand the problem well enough to connect with their clinical friends and their IT data friends to show those gaps, find out where they are, point at them,
Yeah.
and pick at them a little bit so we can bring in the best practices we've learned from all of our other explorations.
Oh, it makes sense. And I'm glad you guys were here. I mean, it was an hour-long session, so the folks who were able to attend Exchange have a lot to think about, a lot to explore, but I'm hoping at least this brief discussion of what was shown here at Exchange will get our listeners and viewers also thinking about some ideas. And I've got articles to link in the description, as we pointed out. But Tom, Jeannine, Erin, thank you all so much for stopping by and sharing just a kind of a taste of what that larger discussion is all about.
Thanks for having us.
It's a
for having
pleasure.
us.
All right, appreciate it.